Hey, everybody, welcome to Cardiocast at the Prehospital Paradigm Podcast. It's our special extra episode for all 2025 on the fifth Monday, so I hope you enjoy. All right, guys, getting back into it. On with part three of the Cardiocast series, and we did the narrows already, the narrow complex tachycardia, bradycardias. Let's transition over to the wides, right? So we've got, again, same concept here. We'll talk about the wide complex tachycardias and then the wide complex bradycardias. Now, I don't know about you guys. I feel like my tachycardic narrows are the ones that die faster on me. I mean, it's just, observational, but my wides are the ones that I'm more scared of. Because wide is, just looks insidious and ugly, and it's like it just looks wrong, right? There's no semblance of right here. It looks
They're
a lot
ugly.
of times they look lethal. And a lot of the stuff.
Newsbreak, they are.
Yeah, right. I'd say a lot of the stuff we're gonna talk about is the varying levels of lethality of them. So again, we'll start with our wide tachycardias. I think what comes top of mind for all of us, of course, is VTAC, right? Falls into that same paradigm that we've been talking about here on our previous segment with the narrows, and we got the unstable cases where we're going to choose Edison. We're going to choose electricity and specifically cardioversion as our initial treatment, and then there's those marginal cases, those stable cases, as gets beat into our head in ACLS, where we'll transition to a medication-based approach in most cases. So in the narrows, Dr. Hill, you stated that cardioversion generally properly done, set up, planned for, is the safest kind of route here. Does that also apply for the wide complex? And again, I'm talking about a perfusing, not a pulse, non-pulse producing VTAC here.
I'll be honest, you stumped me. I don't know, because obviously that's our go-to if they're unstable or they're pulseless, right? We're going to cardiovert that out, but that doesn't bear out into treatment, right?
Right.
We don't immediately jump to cardioversion of those VTACs. We treat them with medication.
Sure.
So not in my training, so I'd say no. It's actually medications is the treatment, unless, of course, they're unstable, and then, again, you're in that forced-to-act scenario, so electricity is going to be your only option.
And I think, we talked a lot about, the underlying causation in the narrow complex. I think arguably it's maybe even more important in the wides, specifically when it comes to considerations of hyperkalemia, right? You want to talk about something that presents as wide and is hard to differentiate from, frankly, everything, and is the mimic of all things, right? One of the things that is kind of top of mind for me is once I realized, kind of how insidious and how many different ways hyperkalemia presents itself, that is, for me, is generally very high on my differential, and I've got a shorter threshold to act on that if I don't have immediate response from the traditional, traditional order set, the traditional ACLS algorithm set. If I do the first couple of things and it's not, I personally have a very low threshold because, it looks like so many things and plays like so many things.
It does. The treatment for hyperkalemia is safe stuff.
It's safe stuff.
We're giving them what? Calcium.
Yeah, right. I mean, calcium and potentially bicarb if they're breathing, maybe albuterol. To hide some potassium, but that brings up a really good point, and that's where I've established a comfort level for myself is, and it took me a while to get there. I'll be quite honest with you. Is I was kind of born and bred on calcium, like this was a staple of ACLS. And then it got taken away from me. It's like, oh, we're killing people with calcium.
With stone hearts.
Yeah, you're right. And we're not. And, now it's kind of walked back in. And going back to that, that low threshold, if they're a non-responder to my standard treatments, or I've got a good story to back it up, regardless of whether they're responding to the treatments, is okay, if I mess up a single gram of calcium chloride or a couple grams of, a couple 2-3 grams of gluconate, okay, so what? They don't have to drink milk for a month. Yeah, it's
and all we're doing is all that medication is doing. That standpoint is stabilizing the myocardial membrane from an electrical standpoint.
Cellular membrane. Yep.
So we're stopping dysrhythmias. Right? We're essentially, calcium in that case is a dysrhythmia, but it's more stopping the progression to a dysrhythmia. So I mean, it's calcium.
Right. And assuming the patient's breathing, that's the other the wild card is I'm going to kind of talk a bit about adding sodium bicarbonate to that, and I know your personal thoughts and your very low threshold for the use of bicarb, just in general.
In the alive patient, I'm not a big necessary fan of bicarbonate. Sure. In the dead patient, I am.
You are, right? Yeah.
But
no, that's actually a very important qualification to make, because those are very different patients when it comes to the elimination of carbon dioxide with as a byproduct of turning that acid into water and carbon dioxide. With the sodium bicarbs, doing that in a closed circuit is a closed circuit being an intubated patient on a ventilator. That's at a fixed rate, right? Yep. They're not going. There's going to be no change. Whereas the person spontaneously breathing mounts a compensatory tachypnea to moderate that. Yeah.
And that's how your body works. Is your body doesn't sense acid bases; it senses CO2. Right. That's how it does that mechanism to say, "Oh, I'm acidic."
Yeah, right. CO2 is acid in the blood, right? And when we've made a bunch of it, because we turned acid into CO2, it's hey, I want to pick that up. Yep. And we've talked about in our respiratory. I think we talked a lot about it in that airways. In the airways part about about that whole compensatory mechanism and letting people breathe that are breathing fast, because they're breathing fast for a reason. We kind of the same conversation we just had with the the tachycardias and compensatory mechanisms and whatnot. So the wide VTACs and I kind of got off on a little tangent there, because I again, when I think wide, VTAC's there, but I'm always worried about what is this in the background, not playing if my usual stuff is, I'm thinking about second or third play down the road.
And before we go there, I think that when we talked about hyperkalemia, that it can cause bradycardias, it can cause tachycardias, and that's kind of one of the things that I think of why not, and maybe should have been said in the narrows, is that with bradycardia, if I have a bradycardic patient and I don't know why, very typically they're potassium.
But yeah, right. Yeah, what's their
and correcting that, everything goes back to normal, right? So potassium's obviously when society decides to do lethal injections, potassium is one of those lethal drugs we give. So potassium can very easily kill patients. That's why we talked about it during kidney failure and everything, because the kidneys are what gets rid of the excess potassium in your body. If you are in kidney failure on dialysis, you can't do that, and that's why we do dialysis, to mainly regulate potassium. Some of the other byproducts of homeostasis and living also get excreted through there, but mainly the big concern's potassium, and if it can cause that widening of the QRS, the whole widening even to a sine wave up until you get to non-perfusing cardiac arrest. Yeah. I think that's why it kind of scares us the most, is because that's the story that's told, as opposed to with the narrows, we're talking about what's the most common narrow complex dysrhythmia. It's sinus tachycardia,
right?
Which can be normal as a compensation maneuver if I'm dehydrated, if I'm in pain, if I'm in stress, if I'm even have a fever, I can mount a tachycardia. Those are normal. That is a normal rhythm to go into when you're in one of those states. It's never normal to have a wide complex anything.
Yeah.
Which is why we get so concerned about it. And not talking about left bundle branch blocks.
Yeah, we need to talk about those things that are going to kind of fool us.
If we're talking about VTAC, that's the big scary thing, right, for us, that we know that this can very quickly progress to, but maybe in our mind they're not as sick because we have all seen those. They appear stable, like, man, I just don't feel good, and they're like, oh, you're in VTAC, and like, I felt like this for like a day. I'm like, oh, okay,
yeah,
we're gonna get you to the hospital, sir, madam.
Do you personally, because I've kind of got a mental model of a wide complex and a really wide complex kind of tachycardia is how it plays in my head. Do you have any differentiation for the VTAC on, how wide that QRS is and what your trigger points for various things? Because if I see it way over a couple hundred milliseconds, 300 plus, I'm thinking really wide.
Mm-hmm.
I'm very much more thinking, hyperkalemia and, nearing sine wave kind of territory than I am. Again, I'll still start with the thing, but in that really wide, if I choose amiodarone early in that patient, that might actually be a lethal decision, right? Mm-hmm. What are your thoughts? How do you kind of digest that? Do you make that differentiation at all? Or do you just...
Based on measurement, no. I think it's more morphology and how it looks on tracing, right?
I got to tell you, I'm not measuring it. I'm eyeballing this, right?
And we say sine wave, but it doesn't actually look like a sine wave. There are still... You can make out QRS TPs in...
Just pulled from the ends.
Essentially, yes.
Yeah, that's...
But it'll have a little... Almost like a little ear to it sometimes, yeah.
I think if you're sine wavy, you're not necessarily going to be as tachycardic. Your heart rate's not going to be as fast as a strict VT.
Also, yes, right.
So it's all I'm.
Nor can it be if you're pulling it from the ends.
Correct.
Kind of mental model
Mm-hmm.
here. You can't get that as many of those wider complexes in this space, right? In any finite amount of space. I guess another very good kind of differentiation is where is that rate playing in relationship to the width.
Yeah. And so if we're talking about that sine wavy thing, obviously bicarbonate's obviously going to be indicated. And again, I have a lot of strong feelings about bicarbonate, but that's one of its indications. And when you give it, you should be able to watch that complex even tighten up as you give it. So going to reinforce like this is from... You're having that sine wavy thing because of the
hyperkalemia.
Also, I think once you get the sine wave, you don't have a lot of time before that turns into asystole. You gotta act quick.
Yeah, I mean we're acting just on lab values, and if we're talking about even just slight changes in T waves, peak T waves, that's very concerning for us that we're going to progress to something even worse. So seeing those early signs and seeing those peak Ts on EKG is going to make us act. Now, I'm not going to necessarily give bicarbonate for that because they're nice and tight. I don't have to tighten up their complexes, but they are going to get all the treatments for hyperkalemia.
And I think the other, I guess since we've kind of got off on a hyperkalemia bit here to begin with, but again, it's the wide that scares me the most, which is why I wanted to start with it. Not that all the other ones aren't scary, but it just scares me the most. I think the traditional teaching in paramedic school is that peak T wave, and and it's really a constellation of things, right? You've spoke to the bradycardia, you spoke to the peak T waves. We've already mentioned the widened QRS, but it could be any combination of those things. And I don't know about your experience, but I've certainly had cases where there's that scale where they say, oh, your K is this, you're going to see this, and your K is this, going to be this. And I've had patients like super sick, don't know why. Maybe just bradycardia, or maybe just peak T waves, or maybe two of the three, this and that. And I've personally noticed that there doesn't seem to be any correlation between what the K comes back if I stick around the hospital and ask, or I do a follow up on it. But that's where it gets kind of confusing, is it can be any or all of those things.
Well, and it can be person dependent, right? If I'm end stage renal disease,
where do I live? Yeah,
I could be really used to being hyperkalemic,
Yep.
and me having a potassium of 6 is nothing. Me having a potassium of 9 is super concerning,
Sure.
right? Versus any of us at the table, which I believe we all have normal-ish, at least kidneys. If we're at 6, we might have peak T waves.
Sure.
So,
no,
and that's really the big key for us, that we're seeing physiological changes secondary to that hyperkalemia, and that first change is going to be EKG changes.
I would say too early in my career, you get out of medic school and you're like, oh, that's peak T waves, and you're like, hey doc, look, I found this. And they're like, nah. And it's like not until later would I realize actually peak T waves are peaked.
They're peaked. Described as if you were to sit on it, it would hurt.
I like that.
That is the textbook definition.
I think so. Yeah.
Would this hurt if you sat on it? You're like,
add them to the book. I mean, can they hold water? They look like fire helmets. Will it hurt?
I guess since we've gone so far down the rabbit hole with hyperkalemia, if they are breathing, there is that very simple treatment that almost every provider level can do if they have those things: the bradycardia, the peak T waves, the widening QRS in any combination.
Albuterol?
And yeah, of course, that's albuterol.
And honestly, that's
large amounts.
Yeah. The only thing that I have in my quiver to treat these patients is medicines anyways. Like, I can't go in there and just reach out and take the potassium
pull the
out
potassium
of
out,
blood,
suck it out, right?
They have to go through, either their kidneys have to process it, or we have to pull it out through dialysis. And contrary to popular belief, going emergently to dialysis just doesn't happen. If you're going to go to dialysis, I mean, not that we can't, but it's still, if it's after hours, it's going to be hours to call the individual, to call someone in, to put you on, the nurse to put you on the machine, have a doctor write a prescription for you to go on said machine, to then dialyze you after hours. Now, if it's during normal business hours and staff's already there, doc's already there, they can see you.
It's only a couple hours.
So yeah. And then you're going to be on the machine for 2 hours minimum, if not longer.
Yeah. The point I wanted to make about the albuterol, and you started down that path, is it's not an albuterol.
No, it's all albuterol.
It's basically
it's all the
albuterol,
albuterol.
right? And I know that from the pre-hospital perspective, we chose the starting point of 10 milligrams, which is 4 sticks.
Which is the starting
dose. And I that was, you honed in on exactly what that's a starting dose. We are beginning the process. You may follow on with another few tanker trucks full thereafter, right? But it's repeat, and it's the albuterol only. It's not the duo neb. So like in our drug box, we've got why don't you just make it all duo neb? I've gotten that question.
Yeah,
before,
so do we.
Right?
Because of this.
This and other, there's a couple other pediatric.
But you're also not going to give, racemic epi here. This isn't what they need. It's the albuterol.
Well, yeah. Albuterol specifically is what's going to take that potassium and hide it intracellularly to buy us time, right? John's point about these patients getting dialyzed is we're just hiding the potassiam.
That's all I'm doing.
Still there.
Hiding potassium.
We're buying time until other
time at a price.
Yeah, time at a price. I love that. Yeah, that's exactly what it is. So, and then I guess the rub there is the patient has to be breathing, and breathing well enough for that to work, right?
And that's why we balanced our drug boxes out too in our system. That's why you have 5 just albuterols. You have 5 separate duonebs, and that's specific in the ALS box. And then if you get into the BLS box, you have more albuterol and more duonebs. Even though we're just using the albuterol, knowing your resources on your ambulance as well, maybe you have a longer transport time where you've given the essentially 10 milligrams, the initial dose. You think you need to get into more. Contact medical direction. You have other outlets you could use 2 drug boxes. Those types of resources are also there. Yeah. Other things while we're on the topic of drugs, if you start off with albuterol, calcium, let's say this goes from bad to worse, it's not working. Something you have to keep in mind is when you get into that bicarb world is you can't just push calcium and bicarb in the same line.
Oh, so very good point. Yeah.
They
crystallize a little.
Yeah, they'll crystallize. They react with each other. We all know dialysis patients are a huge challenge to obtain an IV on, so this might be somebody that you have, seeked IO access for. I'm not saying you cannot give bicarb and calcium, through the same line, but you need to flush
Flush
them
it
really, really, really,
diligently.
really well. In between those.
You know, I've had people say to me, "Oh, it's not that big a deal." No, if
It
you
is.
like if you
It's a
I've
huge
taken
deal.
expired, both and put it in, and it's remarkable. It is not subtle. It legitimately turns white.
It's
and
extreme.
crystalline. It is very extreme.
Yeah.
So if anybody's like, "Oh, this isn't a big deal," it truly is, right?
Yeah.
You're making a million little microemboli to spray into your patient's lungs, brain, and heart. Nothing bad can happen from that for
No,
sure.
not at all.
But but never. That's a great point. The little bit back to the albuterol thing is, put all 4 of them in the neb at the same time,
Yes.
right?
Yes.
Don't lose track of it. I've had providers like, well, I know I needed to give 10. I just started 1 at a time. Just dump all 4
It'll
in.
fit.
Yeah.
First of all, it'll fit.
Yes.
And that's a great point. Second of all, and most small volume nebulizers will take at least that much volume. More importantly, when I drop them off to you, it's super easy and nobody has to think. I can just point and go, when that finishes, that's his first 10 milligrams of albuterol, right? Then you can just let it run, and but that starts sputtering. Okay, well that's the first 10.
Yep.
You can reassess, get your values, decide if they're a candidate for more.
And albuterol is not in our first line for hyperkalemia anyways. It's in the list, but we're giving other medications. We're giving calcium's going to go in there straight up. Always get it. And then they're actually from us getting insulin. They're getting
insulin
and glucose.
Yep.
And that's going to tuck away more of the potassium than anything into the red blood cells. But definitely the albuterol's the next line.
Somebody's probably out there asking, should we preload them with the dextrose for you to give the insulin when we get to the hospital?
Nope.
Yeah, no, I've had that question asked. There is some timing that needs to happen there.
There is. Interestingly enough, I was always trained glucose first, followed by insulin. Mm-hmm. There's been a change in that, actually.
Oh, is it?
We actually give insulin first,
That's how
followed
I know
by
it.
glucose.
Oh, really?
I know, yeah. Had a whole conversation with one of my clinical pharmacists about it.
Oh.
That they're actually giving the insulin first, which I find interesting. Exactly. That's what I said.
Was there a cited reason you remember?
Not that I remember.
No, yeah. It was like, okay.
Yeah.
So we beat the super wide stuff that really kind of worries me right off the rip, and what I'm kind of inherently always mentally planning for. Who's this going to be? Who's going to be this hyperkalemic case that we should be super concerned about? Dialysis, we already talk about.
Yeah.
That's a slam dunk. That's hyperkalemia until proven otherwise. It's like you see a shunt, you see a pigtail hanging out of there. Okay, it's hyperkalemia until proven otherwise kind of mindset. It's funny that we were talking. We had class right before the Cleveland running marathon, and our students go as part of their learning. Part of their learning capacity, and one of the last things I said is, if you catch an arrest during this, as a hyperkalemia top of mind, this is the case this is the concerning case for hyperkalemia. Yeah, do the things you were taught, but have a short trigger for these. The other thing we've done, when we're still kind of talking about that in this most recent protocol revision, is I touched on dialysis, and we kind of packaged the use of calcium preparations and bicarb in the arrest setting, right? And we were just kind of very specific to, if dialysis patient, then do this. But we've broadened that because there's many cases that are concerning for hyperkalemia, including the dialysis patient, but, could be a multitude of different things. We broadened that specifically for that reason, to catch the runner that goes down, or
athletes just in general.
Rhabdomyolysis.
A rhabdo
Just like
case,
extreme athletes in
something
general.
like that, right?
Especially going long durations.
You're worried about burn patients. You're worried about crush patients.
Yep.
It all kind of fits in there. I mean, we probably so much wouldn't, but obviously post our care, definitely looking for that.
Sure.
We do. We typically don't see those that rise. If it's an immediate burn or crush, we typically don't see the hyperkalemia in those cases. If it's delayed, it's absolutely a concern. Probably plays more into your selection of RSI drugs. So we don't want to necessarily use succinylcholine in those patients, but
Yeah, that's why we went away from it. Yeah, just
Part of the reason. Well, I mean,
Part of the reason.
there
not
was
part of the reason. I mean, there's a multitude of reasons why we chose
but,
rock.
You know, there was
sucks, but yeah,
but there was absolutely a case in our system when we had succinylcholine. Was it a dial? I'm almost sure it was a dialysis patient that didn't do well. As part of their RSI, and later the K was 8 or something. It was they were super sick and got it. Simple thing to miss. It was a simple thing to miss in the field, and again, we just chose a safer agent for that space.
Yeah.
So now that we've turned this into the potassium episode, but what makes the heart go squish? Sodium potassium pump, right?
Yep. My first
alterations of that are lethal.
I think my first cardiac arrest as an attending was I was on my way to dialysis, and then they end up in cardiac arrest.
Yeah.
Can't get a clearer story than that.
Yeah.
And I had a certain nurse manager saying, "Oh, why are we doing this? They're on the way to dialysis. We have to rule this out." And I got them back afterwards.
Yeah.
So.
All right. So let's say we don't have these super wides. We don't have the, we are presented with the stable VTAC. Where are we at right now with stable VTAC pulse producing? Where are we at right now with lidocaine versus amiodarone, right? So as a guy that came up on lidocaine, watched it work, and then got told, nope, that doesn't work. This is better.
This is better.
And then, we now know, that the was better was, well, we had data for this, and we had no data for this, because the lidocaine really was not studied. We had anecdotal evidence, and that was about it, and we used it because we just watched it work. And then we had some data, which actually was, if I remember, I'm stretching my brain here a little bit, was admission to ICU data.
Yeah, I think you're right.
I think it showed a superiority in admission to the unit, not necessarily outcomes. Mm-hmm. So suddenly, lidocaine was the devil, and we had we chose amiodarone. I'm not knocking amiodarone. I've used it. I think it's a good drug. Is that our only choice anymore?
Nope.
Yeah, I think the pendulum, like many things in medicine, swung right back, right?
Yeah. So now, at least clinically, amiodarone's our first line, the lidocaine's our second line.
Yeah.
So not stably, but for my unstable patients in cardiac arrest that are like VT Storm, they're getting 100 milligrams of IV lidocaine as hope. And I've seen it work, and I have not seen it work, but it's still it is a antiarrhythmic drug that we definitely use. Still, I think first line is amiodarone.
Oh, for sure. I think the other thing that's the other kind of pendulum swing we've seen, I know there's some studies that shown, hey, lidocaine is at least as viable in most of these cases. Outcomes are at least, the same as of amiodarone. Personal takeaway, and I'm broad brush stroking that wildly here. But I think the other piece of that is we've backed off the, I'm sure you guys remember, it's just like, choose one antiarrhythmic and never give another one, right?
Correct.
You never give another one. And first of all, that was a hard pill to swallow then. I remember it's just like, well, if it's not working, why am I going to keep doing it? It's, definition of insanity, doing the same thing over and over. Expecting different results.
When in other classes of meds, we use a different drug.
Yeah.
That, opioids are a great example, right? Sure. You can give you might give 100 fentanyl to a patient. Like, I don't feel anything. You give them 0.25 of Dilaudid, and they're like, oh, my pain's gone.
Yeah.
So, just
everybody's different.
Everyone is different.
Yeah, everybody's different. No, I think we have seen lidocaine and amiodarone swing back and forth, and then essentially say they're on a equal playing field, for lack of a better word, or they both work. Yep. So we have both options, and both in the adult world and the pediatric world. I'm just going to go with the cardiac arrest side of that. But it's just, I don't know, they're both there. They're both options. But I agree with you, too. It's nice that we got out of the mindset because we were all trained, well, you picked amiodarone, so you're going to ride that horse and that's it. But if you have both drugs available, it was always, well, you can't use the lidocaine. Now I think through some of the podcasts that we've done and talking with some of the other medical directors, well, I've given all of my amiodarone and it did not work. Yeah. And now it's like, oh, well, you could try lidocaine. So there's options out there as well for back and forth, which is kind of nice.
That's a great point to make, though. I mean, if I'm calling the medical director and saying, hey, I tried this thing. What do you think about me trying that thing? He's going to probably be like, yeah, try it. I mean, maybe the body's going to react different to it. So
yeah, and everybody's different, so you could respond differently to that medication.
With your amio load, though, right? You're gonna, I believe it's 150 over 10 minutes
for a perfusing patient.
For a live patient.
For an alive perfusing patient. Most, we'll say most, aren't. From the time you're going to start that medication till it's finished, you're probably going to end up at your destination before that.
Sure.
Unless you've got a really long way you're going to
yeah.
travel. But then at that point, you're going to they might not have converted out of it. You might have gotten your load in, and now you've gone to your drip. But that drip, we're going to, again, like I said in the narrow complex one, we're going to probably run that drip for an hour before we say, maybe this isn't working. Yeah. So we're going to be at like 60, 75, 90 minutes before we maybe pull into a second drug. Now, if you're in the unfortunate circumstance that you're an ALS unit transferring for 90 minutes, might be within your purview to change, but that's highly unlikely in most of where everyone practices.
Sure.
In a facility, maybe they're going to be like, if they don't convert in the next hour and you have an hour drive, we might have you do lidocaine.
Might have you do this, right?
Yeah.
Might. But
I should have expanded a little bit on that versus just like, don't flip from one to the other at a rapid rate. It's not going to happen that way. Yes.
If I give them both at the same time.
Yeah, if I give them both at the same time.
I get all the best.
I give one in the left AC and the right AC.
And I think that was probably the original mindset from ACLS, because that was certainly at a time that I can remember, and it was almost advocating. He's like, what do you give? You give them epi and lidocaine basically at the same time, right?
Yeah.
And again, we've backed off on so many different things, right? It was probably just to dissuade us from doing exactly that. Amiodarone, that didn't work.
Switch.
Let me go to this.
Go to this, right?
Yeah.
But there's variables. It's not necessarily, not necessarily cut and dry. And, those weren't, again, it's a condensed course.
Sure.
They're bullet points. So you brought up electrical storm.
Yes.
And
something more terrifying than just VTech.
Correct. But essentially, with the exception from the perspective of this isn't going to be stable, and there's not going to be cardiac output, so we're talking about the VFib patient, right? We changed to defibrillation rather than cardioversion because there's nothing to sync to because of the irregularity. What changes in our drug profiles here? What are we changing up in that space?
Well, for a VT storm, we don't have a perfusing pulse. We're getting a much larger dose of amiodarone to start with, right? We're getting 300. And then if that doesn't work, we're giving 150. So we're loading them with 450 milligrams. If that's not
the book, that's the point I needed you to hit, right?
Yeah, that's my kind of viewpoint on all of cardiac arrest. Just hit them hard, hit them fast. Yep. It's either going to work or it's not going to work.
Make them not dead.
That's the goal. I mean, and ideally to get them to a good neurological outcome at discharge. That's the ultimate goal.
Yeah.
And that's what we focus on. But we do want to hit them fast. We want to hit them hard. We want to hit them with everything. So that's a lot of amio. 450 milligrams is a considerable amount of amio.
Yep.
At that point, if you're already done that and they're going to get multiple shocks, we're probably going to do dual sequential defibrillation on the patient. We're going to talk about changing our vectors on the patient. Mm-hmm. We're going to probably give them lidocaine, and even despite all of those things, it's probably not going to work. Right. In a true VT storm, we cannot get the heart out of its storming electrical activity. I've had at least 2 that come to mind. Now I've had 3. I think we got 1 out of it, and the other 2 died.
Yeah.
So one, the first one that died had everything. It was a witness cardiac arrest and had bystander CPR, bystander AED. Local ambulance was there, took over ACLS care, shocked multiple times, loaded with amio, and I'm like, this. He had the perfect story to survive, right? Witness cardiac arrest, like CPR, essentially as he
hit the ground.
Like he should be neuro intact, and despite our best efforts, and total time I think we worked in was 80 minutes because I think I even gave him I gave him TPA to break up any clots because what else would
what he got to lose at this
exactly.
point? Yeah. And I think.
And he didn't survive. And the other one was a patient who actually was on bypass up at CMC prior and got discharged and then came into me for shortness of breath or something and then progressed into VT Storm. And myself plus 2 interventional cardiologists were in the room trying to resuscitate him and did everything. And he literally he needed ECMO. That's what he needed. He had this before. He survived it with ECMO. Now he needs ECMO again.
He needs to go back on the pump, yeah. Now, all of those things you just described from the hospital side of things, nearly all of those things we can do in the field, right?
Absolutely. Yep.
You know, the consideration of, you know, assuming we don't, again, it's a storm, we can't get them out. We've popped them a couple times with our defibrillator. You know, the option to get another defibrillator.
We can change vectors.
Yeah, we can change vectors.
The changing vectors, I think that gets overlooked, and I think for some reason I've had providers kind of like regurgitate that to me in the context of, I can only do that if I have two monitors, and all you need is 2 sets of pads,
correct.
Right? So, you know, if you put a set on, you know, apex sternum and a second set on
AMP
and anterior posterior, you know, you can switch between them.
Yeah,
you know, that's not
yeah, there's nothing wrong with that.
Yeah, and you can try that. You know, you can change that up. Whether that's, you know, weird anatomy, poor pad placement, weird conductivity through, you know, the transthoracic space, whatever it may be. That can be done even if you have one monitor and you're kind of by yourself and nothing else is working. So that vector change, you know, trying the electricity from, you know, different pathways. Not predicated on having a second monitor and being able to do
double sequential,
right?
I mean, still, some departments run 2 squads. Maybe their engine's carrying another monitor.
Or maybe their chase vehicle has a monitor in it.
That's true.
Or maybe the chase, right?
Yeah.
So.
Yeah,
or maybe you're a basic with an advanced response later, that your basics are there with their monitor and AED mode, and then you get paramedic help that arrives as a second monitor.
And we've seen that work. You know, we've seen that work at CMC. We've seen that work at Portage.
I've seen it work,
It's just, you know, it's another option that you're able to take out and try.
Yeah, we talked about, you're going to change up meds. You're going to try the stuff you haven't tried, right?
Sure.
So you've run out of amio. You're going to transition to lidocaine. If for some reason you started with lidocaine, you can transition to amio. Where, for you in the hospital, John, where does, and then some EMS agencies might have some legacy drug boxes that will still have esmolol in it. Does that fit in anywhere for you? Is that something you just consult with cardiology? Can you find some dusted off in the building?
We have esmolol. I've never given it for that, and I've never been told to give it for that.
Yeah.
So it wouldn't even come into my purview. This would be something where if I was working at cardiac arrest and I've given them amio, I would give them lidocaine to the next phone calls to cardiology for any other. And the other thing at that time, and when we're talking about cardiac arrest in this case, and we've said it before, is we want you guys to work these in the field because I have very little to offer that you don't, if anything, honestly.
Yeah.
And really what they need is high-quality CPR. They need early defibrillation. That's what they need. Mm-hmm. Taking them to me burns time, right? It might take you, at best, say 5 minutes. At average, 15, 20 minutes.
Sure.
It's the local ER. I get them. I reassess them. I listen to the story. I see what my presenting rhythm is based upon everything you've told me. I start down my pathway of continuing epi and the drugs that you guys have continued. If we need to start amio drip or I need to give lidocaine, by the time that I'm getting to I don't want to say a stable point, but a comfortable place in that resuscitation, downtime is going to be at least 30 to 40 minutes.
Yeah.
And we're approaching the 0% of having a good neurological outcome. So at that point, it's a serious conversation we have is like, at this point, if I even were to get them back, is there is there anything left to say, right? Are they just going to be a vegetable? And that's something that we have to consider. And by the time that when we talk about the VT storm, which at least maybe gives me some hope that there's something there left to save, especially the guy who like had a witness cardiac arrest. And both these V2 storms were witness, whether that was the one guy arrested in the emergency department, so obviously immediate CPR, and arrested at work with immediate CPR. So they had everything going for them to survive that and help that there was not that there wasn't any brain injury. There's still likely going to be brain injury, but a minimum amount of brain injury. And I think that Dr. Singer's lecture this month does a good job of talking about like making sure we're continuing flow and limiting our time off the chest and making sure that we're not causing that anoxic brain injury. But when we're getting to these prolonged time frames, there's going to be brain injury. We don't have a perfect way of making sure that we're perfusing all of the organs short of ECMO. ECMO is the ultimate answer, right? And we've talked about ECMO and how that might be the next big step in these survival rates, but it's going to be hard to canalize someone at the deli counter that goes into cardiac arrest. Doing it in the ER is a lot more feasible, right. But in a big cardiac center like Cleveland Medical Center, obviously we can do it there. We were doing it there. The other Cleveland hospitals are also doing cannulations in their big centers. Mm-hmm. How do you get that out to the community?
Yeah, how do you get out to more rural communities, right? In our system, even like geographically. I mean, I think we talked a lot about this when we were at Shaker doing their live. We talked about, the close proximity of some of those ambulances, let's say, that are like 15 minutes from downtown, right? Then they have that available space. But now let's move out to where we're at right now in Chardon. We just don't have that resource, unfortunately.
Your resource is the county hospital, which just happens to be UH Geauga.
Yeah, but I like to say yet. We're evolving. We're evolving quickly, too, I mean, this was not even thought of at Cleveland Medical Center until, I think he said 5-6 years ago they started trialing and doing. So, not that it wasn't thought of, but it wasn't feasible yet. Now it is. So
yeah, and you never know. I mean, as technology changes, ECMO machines might get smaller and more portable and just, push out, and it'd be better to move them out to the community hospitals and be a resource that's available at more centers with, perfusionists and those items.
I mean, we're already talking about community hospitals doing it, right? It's already expanded beyond CMC, and we're they're eyeballing Elyria now.
Really?
Elyria, Parma.
One of them,
One of them. I can't remember which. But they're hustling. They're hustling to get that out into some of the community hospitals just for that reason, right?
Well, to your point, not to take this away from wide complex, but the other thing too is us putting the patient in the back of the ambulance, just driving them to the hospital, essentially expecting a different result a lot of times too. If we're headed down a termination path, makes it very unsafe for the providers, very unsafe for transport during that time. So that's why our protocols allow field termination if we are not in that storm.
Well,
if we go into another rhythm,
things, right?
Sure.
Like we're not when we're having you call it in the field, it's going to be PEA area systole, right? It's not a rhythm that we can do anything with.
Correct.
Right?
So we're only transporting patients that are in that. I guess was my point of that.
Yeah. Good point, John. Other than the ECMO, or any other bag of tricks that you guys have on the hospital side for that storm?
I guess maybe I don't think it's a bag of tricks. I think the consideration to be is, am I missing torsades, right?
Yeah.
Do I just maybe throw some mag at this patient because this could be torsades, right? The big push right now, and for obvious science reasons, right? We want to decrease the time off chest. We don't want to lose the forward momentum of that blood flow in the chest. We're having, and we talk about during education, right? When you're doing those pulse checks, and when I do it in the emergency department, my job is to stand on the groin and I feel for every single compression that they're doing, and I'm watching the monitors. And when we're doing our pulse check, if I have a Lucas device, I pause the Lucas, I interpret, and I restart, and we stop CPR for maybe 2 to 3 seconds because I'm prepped to go. I'm like, nope, I don't have a pulse. That's my rhythm. I see we're restarting CPR, and then we're just continuing on.
And you can defibrillate through that, Lucas, right? If it's a shockable rhythm, we can continue to defibrillate. And I think pulse checks are where we do lose a lot of time. So I think Dr. Singer's lecture And that brings up a valuable point, and a lot of people forget that, is find your pulse while you're doing CPR. Find your pulse while your glucose is
Charge
running.
while you're finding your pulse.
Charge, because you can always not shock,
can always
right,
dump
and save
it.
a lot of time. So,
and two things, like it's easier to know where the arteries are when you have pulsatile blood flow. I'm doing CPR, I can be able to better identify my landmarks in the groin. Second, it's my check that you're doing good CPR. I've got a great pulse with what you're doing, Ray. Keep that up. So it's that feedback to know that I'm doing good. Like, oh, you're not doing as good as you are. Are you tiring out? Do we need to switch you out? Did your hands move a little bit? Did you come down? Did you go up? Do we need to reposition? Are you not allowing the chest to recoil enough?
Yeah.
That's all I can say. Oh, I feel a change in the volume of blood going past my fingers. Do we need to change what we're doing from a compression standpoint?
it's giving you that instant feedback,
Correct.
essentially, right there.
Since you kind of walked down that path from the hospital side of things, are you personal practice? I know that there are people that, I don't say use it as a crutch, but they lean on this more than pulse checks from the physician hospital side of thing. But where does ultrasound fit in with specifically Lucas placement and making sure to optimize compressions?
Sure.
Where does that fit in for you personally, just out of curiosity?
I really like ultrasound. I think ultrasound's a great tool for us. I don't use it as much in my cardiac arrests. People that love ultrasound like to use it, and it's a great check to not necessarily, it's going to be hard when you're moving on a patient to hold that probe in the right spot and be able to get a great window on the heart. It's great for looking at the heart when I'm not doing compressions. Like, is this a fib, right?
Yeah.
Can I see the muscles fibrillating, and that's what's going on? Maybe I'm concerned that asystole really is an asystole. Is it fine V-fib? And can I pick that up on ultrasound? Or if I look at the heart, and am I actually seeing some organized activity to it? And then we have the kind of concerns like, or am I seeing just the crap ton of epi that we dumped into this patient? They've had 6, 7, 8 milligrams of epinephrine, and they're just having some contraction secondary to the epinephrine. Yeah. So it plays a little bit of a role. For me, it more kind of clears up the picture that I'm already seeing. It does that verification process of, yes, there truly is no cardiac activity, because I can document and visually see true cardiac standstill, as opposed to just relying on my be able to palpate a pulse on a patient. It's a great tool to have. I don't necessarily use it on all my cardiac arrests, but it's a tool to use.
Yeah.
When I was in training, the big talk was from some people about even placing A-lines on these cardiac arrests. So if you have enough people there, and in a residency you would have multiple people, that just have someone gaining peripheral access, so that way you could have pulse to pulse to see pressures when they regain a pulse back. Get better monitoring to how your resuscitation's going.
I think the one thing that we started to kind of talk about was the bundle branches.
Yep.
Things that maybe aren't necessarily wide, but there's some structural change there
and they look scary, right? If you're new in your career,
a novice,
a left bundle branch can absolutely look like a STEMI.
Mm-hmm. Yeah, it's one of the biggest mimics.
Yeah, and we always teach, don't look at the computer interpretation, but it follows computer interpretations too.
Mm-hmm.
So definitely left bundle branch blocks are wide. They can be tachycardic. They are normal-ish, right? There's lots of people walking around with left bundle branch blocks. New left bundle branch blocks are going to be obviously evaluated by us, but again, I would even say it goes to, do we have an ugly-looking rhythm strip that's VT but they're stable, versus is this a left bundle branch and they're also stable? Treat what your patient looks like, not what that single solitary piece of data is giving you.
Yeah,
It's like we always circle back to that.
Picture. Yeah.
Almost.
Yeah. I think, and being able to read bundle branches too can be challenging for a lot of providers. I remember when I went through medic school, the book talked about turn signal methods and looking at different leads, and it's actually pretty simple if you really want to dumb it down. I mean, you do a 12 lead, where is stickers 1, 2, and 3 going? It's to the right side of the heart, and stickers 4, 5, and 6 are on the left. That's where you're looking. That's the side that you're looking at, and if you see elevations there, that's the side the bundle branch is on. You can make it pretty easy, so don't overcomplicate it.
No. Actually, the firefighter medic that taught me the most on how to read EKGs says to take that EKG, you're going to look at it from the precordial lead side. So you're going to take that and turn it like this, and wherever the arrows are pointing with your leads,
There
if
it is.
points to the left, it's the left bundle. If it double points to the right, it's the right bundle. Like,
Fair, yeah.
that is so easy.
Yeah, no.
Yeah.
Even this doctor understood it.
Well, I mean, he's a firefighter medic.
That's great.
He loved EKGs,
Yep,
and
yep.
that was how he taught us in residency. That's how he taught the paramedics on his
This department.
Yeah.
Yeah. That's awesome. Oh, that's great. Great little tidbit.
And I think I've talked about a lot in the last 2 episodes with narrows and wides, and maybe I lean on it too much because I'm more experienced now that I talk about, morphologically that looks like this. But I've seen thousands of EKGs.
Sure.
Yeah.
And that you talk about pattern recognition, and especially in young learner. When I was a young learner, I didn't quite understand quite that pattern recognition, but I'm at that point in my career that, morphologically it doesn't look like that. Well, what do you mean by that? I'm like, well, if you've had a few years of experience of looking at these, we'll talk about how does the ST segment look? If we're looking at, you talked about, I think this is a STEMI, but we're talking about, no, that's concave, not convex. Those morphological changes tell me a lot more of what's going on with the patient.
Yeah, for sure.
And then one of the great things I think that for all, not necessarily narrow, wide complexes, but for for any EKG interpretation, we're talking about myocardial infarction, and STEMI specifically is looking for reciprocal changes. So if it's a left bundle branch block, it's going to look like a left bundle branch block, and you're not going to have those reciprocal changes to show
you bring up
STEMI.
a really good point. I think finding ST elevations in 2 consecutive leads is kind of like, I gotcha, but then when you see it in the reciprocal leads, it's like, I definitely gotcha.
Yeah.
And it's like when you can verify it with that. And again, there's cheat codes to remembering those too. I think we talked about those before in episodes, but they're just as important as the facing leads. So,
Absolutely. And just understand that that's the other side of it, right? It's you're showing the ischemia from the other side.
Yep.
And that's
if it's
why.
inferior, take that peek around the corner and see if it's posterior. So
Yeah, absolutely. And there's lots of reasons why you're going to have ST segment elevation. It may not be from an MI. It might be from pericarditis.
Yeah.
It might just be a left bundle branch block. It might be a number of reasons. But that's the big thing that I always point out to learners. Like, it doesn't. Do I need 1 here or 2 boxes here? I'm like, no. In the precordial leads, you'll need 2. But what else do you need to look for? I'm like, what don't you see? It's like reciprocal changes. I'm like, there's a big tell.
There's
right
the answer.
there.
There's your answer.
Also, with the wide complexes, and I touched on it in cardiac arrests, is looking for that torsades. I think that if you're taking the big step back and you have the time to analyze what's going on, torsades is obvious, but I don't think when you're in the moment, we're trying to minimize our time off chest, and we're doing CPR, or we're trying to do so much else that we might be missing that undulation.
Yeah.
If we're just, I'm looking at the monitor, I'm going back to work, I'm looking at the monitor. Instead of
Looks coarse.
You're doing that in 3 seconds.
Yep.
Yeah, you're doing. I mean, our
Yeah, you
goal is
might
to do
miss
that in
it.
3 seconds. Yeah, it's quick. So yeah.
So I guess that'd be my only thing. And I bring that up because I had another case that I just reviewed that after taking that, and it was a case review, right? So I was looking at the case after the fact, and I was able to look at from a long strip. I'm like, that undulates like that. Like my gut says that's torsades, to the point where like I called Stryker and had the conversation with the team that reviews those recordings to be like, I have concern that this is what this looks like.
Yeah.
What do you see? Because I'm interpreting this through the monitor data while Lucas is on. Like, am I seeing things or am I not? And we were able to walk through it and like, no, the problem in this case was they were doing CPR really fast. So they didn't have a Lucas on. They were doing CPR at about 150, 160 times a minute. And it looked like, and because there's changes, it looked like torsades.
Sure.
So it looked like VTAC. And it was fast, so it wasn't as slow as what I was expecting it to be, but they were doing manual CPR. But then when you saw the compression stop, it was asystole.
Gotcha.
But it's just that guttural reaction.
Yeah.
Like, ooh, that's 160 times
yeah.
a minute, and that it's changing and like that.
Yeah, that was just their compression rate, depth, all that. Looking on
Correct.
when they antidote it.
There's some fundamental differences if we do have torsades in our shift. Are these patients getting the same? Are they getting the same medications as our VFib VTAC, or do we have to make some changes here?
You need to make some changes.
Yeah. Obviously a loaded question. But I guess why the magnesium, right? So the magnesium is the change there, and if the patient is pulseless, we're going to defibrillate rather than cardiovert. But why the magnesium change? It seems like if amiodarone and lidocaine were effective on all other wide rhythms, this other wide rhythm should be equally as adaptable to these medications as VTAC.
Sure.
And I think that's going to go to causation, right? Is more often than not, torsades, comes down to hypomagnesemia due to chronic alcoholism, chronic malnourishment. When you start looking at it and you correct that, then you straighten that out. It's not just a treatment. You're actually correcting causation of that. Has anybody ever tried to sync up torsades?
I have not.
I've heard that it does. I've never tried, but I've heard.
It won't work.
I've heard that you can't get it to flag the R wave. But I've never personally had a situation where I tried.
It may not be pointy enough.
Yeah.
It's a doctor term.
And likewise.
So you can't sit on it.
Yeah.
Also, yeah, it won't hurt if you sit on it.
if you sit on it.
But that's I think I've seen maybe 3 in my entire career. I can't say that I've seen a ton of it, right? And only one of those in the field. So.
And typically torsades they're going to be sinus.
A run of,
right?
Yeah.
And then they're going to come back. So it might explain all of a sudden why you have a syncopal episode because you're having these runs. But
these runs VTAC slash torsades.
Fast ugliness.
Fast twisting ugliness. Mm-hmm. We're gonna put that on the shirt with doctor words as well. To your earlier point, John, you're getting down an algorithm. You've tried the lidocaine, you've tried the amiodarone, no success. You're not totally decided on whether or not this might be a ugly torsades. Is there any harm in putting the magnesium on?
Not at the doses that we're giving.
Yeah,
if you're giving 2 grams, think about it. We give pregnant patients 6 grams right off the rip, and it's not going to be till after that we ever see concerns for hypermagnesemia. But 2 grams is nothing. We give 2 grams all the time if you're just slightly hypomagnesemic in the emergency department. If you've have a viral illness and we take your mag and it's low, you're getting 2 grams right off the rip.
Get mag, right? Yeah.
So I can't give it to you orally. You're just going to either throw it up or come out the other end. So you need to have that IV replacement. I had a recent admission from a young college girl who, I don't even know if her magnesium was reportable. So she got a little bit of magnesium, and she didn't really want to be admitted. So I signed her out. She ended up staying in the hospital for a little while to get her mag repleted.
Wow.
But she was a GI bug.
Yeah.
She just got herself all the way down.
Wow. Not reportable. All right. Well, I think that takes us out of the wide tachycardia. Is there anything else that on your guys' mind with the wide and fast?
I think a couple of things we talked about, narrow, wide. We just say synchronized cardioversion, we're not really talking about the joules for either
Oh.
one, right? So maybe we should talk a little bit like
Sure.
I was always taught top of the heart, not as lethal, not going to kill you immediately. So we started with a little bit lower joulage. So like I'd say your initial, I think per our protocol is 50 joulage.
Joulage. That's gonna go on the shirt too.
Top of the heart, good way to think of it is like you're probably going to start at 50, work your way up. You can increase it if needed. Bottom of the heart, like your VTAC with a pulse, we're going to start at 100 joules. Needing more energy, you can also increase that. So I think it's good to know your protocol. I mean, AHA will lead you down that path as well to increasing your dosage up to defibrillation dosage. But other things as well with cardiac arrest, flipping this script to pediatric patients that are in VFib pulseless VTAC.
Very nice.
We do have some aids that are in our drug box. So, it's really great to be like, hey, I can give 5 milligrams per kilogram of amiodarone to this pediatric patient that's in VFib or pulseless VT. That's a pain to do at 3 a.m. So you have Certidose. You can use lidocaine, measure them with the tape, and it's super simple. So I just wanted to throw a couple of those tidbits out after we get to the end of that.
Great to mention.
So it's just, that's already a stressful.
Awesome. Hand heavy is also really good. So
You're leaving the most important one out, my friend.
Yes.
Yeah.
Oswald?
One dose.
Yeah.
One dose.
One dose, yeah.
One dose, our protocol, right? So, I mean, those are some of the things we use. I don't know. People listening might use something different, but those are just
There's
some
a bunch
of
of
the
tools out there
to help you decrease errors, to get
There's
to
free
success.
apps on your phone to help.
100%.
Yeah.
Yeah, and I know a lot of people always complain that there's not a timer for 2-minute timer built into the monitors, and it's like there are apps for that too. Actually, and they
Yeah.
we're
Yeah.
pretty
Code
cool.
Runner's a good one.
I do wish that somebody would add one to their monitor though. They just have a timer button.
Yeah, there's some workarounds with AED modes and stuff like that to
for sure.
kind of help prompt you. I agree. I don't expressly love them, but nevertheless, Ray, going back to your point about the joules, you're right. The classical teachings of 100 or more for ventricular for arrhythmia, going back to my medical director's preference, he's totally okay with us coming heavy with specifically the narrows, but as a guy who himself has been cardioverted many times for his arrhythmia, he's like, I want you to do it less rather than more, right? So, he's totally okay with us coming heavy, maybe, starting at 150, 200, and doing it fewer times and, getting first shock success rather than,
Having to repeat.
then, tiptoeing into it and hoping for success.
I'm definitely in that category, personally.
The ones I've been involved with that I've personally seen, 100 has typically worked with pulse. VTAC with a pulse, with an unstable patient, and it's been pretty successful with 100. I've seen ER physicians have to repeat, occasionally if they have any type of re-entry, they've increased the joules, but no, that's a good point.
Yeah. So
I guess I'm also, typically it's the patient that has a large body habitus too, so I know I've got a lot of tissue to get through.
Sure.
Yeah.
It's one thing, I'm not gonna shock a 90-pound 80-year-old
Grandma,
female
yeah,
at 200, 360 joules, right?
Yeah.
I'm going to start at 100.
Work your way up.
Yeah.
Yeah. Common sense.
As opposed to a 300-pound guy who is in this, I just want you out of it. We're going to go whole hog.
Whole hog, man.
Sir, this is going to hurt. What?
yeah. That. But no, that's all very good stuff. And the pediatrics like that ad there.
And the peds are scary, right? Like kids shouldn't die, right? It's a hot take. And it's terrifying when you're faced with a kid that shouldn't be in cardiac arrest, right? So getting anything to like offload your cognition with that, and I see when I'm dealing with pediatric cardiac arrest, there are a lot of errors, both pre-hospital and in the ER, like whether we're not setting our monitor to the appropriate power, are we not using pediatric pads to attenuate? Are we giving the wrong dosage of medications, or even just documenting the wrong dosage of medications? It's a very high stress
situation.
So.
Yeah, and cute too with kids. To your point about energy, kids are pretty resilient. So if you started higher with kids, with synchronized cardioversion, and PALS is, speaking specifically to AHA in our protocol, PALS has even expanded a lot of those. Before it was just 2 and 4, right?
Yep.
For defibrillation doses specifically, it was 2 joules per kilo and 4 joules per kilo. Well, now that's 2, 4, up to 10 joules.
Up to 10, yeah.
So,
that's a great point.
PALS has really expanded their component there to let you look at a larger window because, well, let's face it, some of the children are getting bigger, right? To your point. So is this a larger child or is it more? Is it a smaller child? But I've heard from a lot of physicians too. If you came in heavy on a kid, I'm not too worried, right? I mean, not adult dose heavy, but their dose heavy. If I have that window 2 to 10, and maybe I started at 6 per kilo, and I hit them there, and I was just like, hey, they were a larger kid. This is why. Physicians are pretty open to children, are pretty receptive to more energy. Pretty resilient.
I actually can't think of I don't know if I've ever had a kid in a wide rhythm. I don't think I've ever given a kid amiodarone that I can remember.
No, most of ours have been assistally
PA. Yeah, that's same here.
Yeah.
So, have you? You can.
We had a recent case of a small child that was had a run of VTAC at the emergency department.
Yeah.
So they intervened. So it happens, right?
Yeah,
sure.
I'm just saying.
I think their asystole PEA progressed to this one run, so we're getting better. We're intervening. But yeah. But I mean, even if I just used one dose right now, if I just picked an 11 kilo kid, our third dose of defib's still at 110 joules. I mean, we're going up pretty high very quickly, right?
It's not an insignificant number.
No.
Yeah. So, all right. Anything else on the Ys? Those are great points about the joules and whatnot. So I guess that takes us to the wide bradycardias, and if you've listened to the narrow bradycardias, not a lot changes in the discussion, right? Again, that underlying cause and why is it wide and slow? We got to think of that insidious bastard of hyperkalemia. And I guess it's also worth noting in those cases, electricity may not work for the pacing, right? That might completely laugh at you in that wide, slow case, especially
until you fix the electrolyte abnormality.
Until you make some impact on that underlying causation. So I guess have a low threshold for moving to. I mean, atropine's also probably going to not be very, very, very effective in said case. You move to your pressors very quickly, in those cases, and then transition. Try your electricity once maybe you've done some, like we talked about, cell stabilization with calcium
But again, another reason why push dose epi is so nice. I mean, it works on so many different levels.
Well, and I think that
it's just versatile. Yeah, I mean, just the versatility. I couldn't say it. Sorry. The joulage was coming out. Sorry. The joulage and now versatility, Lily. Sorry, Doc. But the versatility of it, yeah. But trying to understand why is it the way it is probably the biggest thing, and I was trying to figure that out.
As we sit here and we talk about it, and I'm really thinking about these bradycardics, there's a lot that's going on, and likely it's that silly thing of when you're taking the test, like what's the next best answer?
Right.
But literally, it's everything that you're doing. It's going to be, we're going to try atropine, we're going to try electricity, we're going to try push dose epi, we're going to try we're going to give them calcium, we're going to try everything kind of all at once, and whatever hits first, that's the first thing we tried, I guess.
Yeah.
Hey, you get the atropine, we're all start pacing them. Why don't you start mixing up from push dose epi, and I'll pull the calcium.
I got the calcium.
And I'll get the calcium, and we'll all meet in the middle and see what hits.
Yeah, go fish.
1, 2, 3, everybody at the same time.
Yeah. Go. Yep. Then when we admit them, we're like, what fixed them? Like,
yes.
One of these 4 things.
One of these things.
One of these.
But by about that time, though, we're going to have labs back, and we can probably narrow down to give a more specific reason to why it happened. But
sure, but in the pre-hospital setting, it's go fish, in some sense.
Well, and to the point, a lot of ACLS is, and that kind of gets beat into our head during training of, especially as doctors are like, well, we want more data, right? We want to know what do the labs say, what does the EKG say, what does the chest X-ray
Doesn't
say?
matter.
Yeah.
It doesn't.
Yeah.
No, it's kind of algorithmic, but we fix this kind of the same way, independent of what information.
Attack it.
Yeah, fix it.
Yeah, attack it. Right. Yeah, see what works. Make them not dead. Right. I think it about rounds out the wides, guys.
I think that's it.
I don't think there's much more on the wide bradycardias, because we've already talked about them on most of those pet peeves with the atropine and the other stuff on the narrows. We're not going to repeat that. But yeah, don't be shocked when the atropine doesn't work on these cases specifically. So, all right, anything else, guys?
I think that's it.
I think that's it.
Let's move on. Let's move on to our part 4 in a couple months.